I will tell you that our first presenter is a PhD who received his MD and PhD in philosophy from Vanderbilt University. And I will say, as an undergraduate philosophy student, that is so interesting to me. He's a professor of psychiatry and adjunct professor of anesthesiology and pain medicine and adjunct professor of bioethics and humanities at the University of Washington. I wonder if he gets lost on campus. Not sure which way he's going. Probably not. He has served as an attending physician in the University of Washington Center for Pain Relief for over 30 years, where he has co-directed the behavioral health services. He's published over 275 peer-reviewed articles, many on the interaction of physical health and mental health in patients with chronic illness. Before I introduce you, I do have to put up his disclosure because we want to be compliant with all things. And so here is the disclosure, which says nothing to disclose. We've now been compliant. Would you please put a big virtual round of applause together for our presenter this morning, Dr. Mark Sullivan. Dr. Sullivan, welcome. How are you?
Hello. Thank you, Ian. And hello from Seattle, where it's changing from foggy to bright and sunny, a little bit cold for us, but it's pleasant to see the sun. I'm sorry not to be in Bend with all of you, but at least we won't get infected. So can we pull up my slides? There we go. So my first talk is going to be on the use of opioids and benzodiazepines in patients with chronic pain. And why is that important? It's important because although opioid use nationally has come down since 2012, the group of patients with taking both opioids and benzodiazepines has not come down much at all. This is a tougher group. It is a group that's important because we have substantially increased overdose risk in people who are both on opioids and benzos. And the clinicians in the group will easily tell you that it's often hard to get those people on both of these drugs off one or both. So what I'm going to do today is talk about why are they dangerous, why are they used, and how do you get patients off. Next slide. So our agenda is going to be, I'm going to go through a case of a patient with simultaneous opioid and benzo use. I'm going to talk briefly about the risks of concurrent use, both in terms of the pharmacology and the pharmacoepidemiology. I'm going to talk about reasons for concurrent use, specifically the psychiatric comorbidities of chronic pain that tend to be associated with this. And then I'm going to spend time talking about the strategies for addressing this concurrent use. Providing comorbidity treatment before withdrawing meds, using Prasasin or tricyclic antidepressants for PTSD, a bit about trauma-focused psychotherapy, and just a short bit about dialectical behavior therapy, or DBT, for complex multi-layered trauma. All right, let's get started. So as I go through this talk, keep this case in mind. He's a composite case. This is not really his picture. That was a picture off the internet. So he is Robert, 49 years old, has chronic headaches, neck and low back pain. He has been on daily opioids for 12 years. However, despite his opioid treatment, he continued to have severe insomnia and anxiety. So clonazepam, a benzodiazepine, was added 5 years ago. And now he takes 40 milligrams of oxycodone and 2 milligrams of clonazepam per day, which he considers quite essential for his survival and stability. However, recently, his daughter found him unresponsive. He was sedated, he was breathing very slowly, and she brought him into the emergency department. He is now appearing for primary care from you. You have to decide what to do with him next. Next slide. So a brief moment about respiratory depression. Opioids produce respiratory depression in a very predictable and well-defined way. They produce a decrease both in the regularity and the frequency of breaths. They do this by action at two brainstem sites, important for respiratory control, the parabrachial nucleus and the pre-Botzinger complex, decreasing the drive to breathe. You could reasonably approximate this that people just become forgetful or too relaxed to breathe. So benzodiazepines do not often produce dangerous respiratory depression on their own. So respiratory compromise is uncommon in pure benzodiazepine ingestions. But if the benzos are taken with ethanol or opioids, serious respiratory depression can occur. So both benzos and alcohol facilitate the inhibitory effect of GABA, gamma-aminobutyric acid, at the GABA-A receptor. And alcohol adds to that it decreases the excitatory effect of glutamate at NMDA receptors. So the most clinically important fact here is that the doses of benzos and opioids required to produce respiratory compromise are difficult to quantify and depend on many factors, including tolerance to these drugs that develops over time, the weight of the patient, the age of the patient, what other drugs or substances are being ingested, and genetics. So that there really is no safe combination of opioids and benzos. We're able to talk about the relative risk of low versus high dose opioid therapy, but we really don't have any dose calculation of risk for the combined treatment. Next. So multiple large studies have documented significant, in fact, between 4 and 10 times increased risk of opioid overdose when both opioids and benzos are being used. So compared to just using opioids, the addition of benzodiazepine multiplies the overdose risk significantly. Just a bit of an overview here. Alcohol contributed 12% of opioid overdose deaths in 1999, but 15% by 2017. Benzos increased even more. They contributed to 9% of opioid overdose deaths in 1999, but 21% in 2017. And benzos were present in 33%, a third of prescription opioid overdose deaths, and 17% of synthetic opioid overdose deaths in 2017. So with the rise of fentanyl and the move from prescribed to illicit opioids, there are more opioid overdose deaths that don't include benzos because fentanyl is so lethal and so difficult to dose safely. Z drugs like Ambien, Zolpidem, Zaloplan, Azopiclone, which is Lunesta, are claimed to be safer than benzodiazepines. The Z drugs are chemically not benzodiazepines, but they act in a very similar way. They're slightly more specific. So recently, Smolowitz and colleagues studied 500,000 patients exposed to Z drugs, and they found that those that were on Z drugs as well as opioids had an unadjusted hazard ratio of about 3.67, meaning that they were about 3.5 times more likely to overdose than people on just opioids. And once you adjusted for the kind of people that tended to get Z drugs as well as opioids, that dropped to about 2.5 times greater risk of overdose. And the use of benzos or Z drugs with opioids is common. In a study of opioid users in British Columbia, 18% of opioid users were also on benzos or Z drugs. And this was more true in females, more true in people who were on over 90 milligrams of morphine or equivalent, opioid use disorder patients, chronic opioid users, patients with multiple providers, lower median household incomes, and those older than 65. So it was a vulnerable group that was on opioids and benzos. Next. So benzodiazepines, are they a godsend or a curse? Well, they're actually both. Benzodiazepines replaced barbiturates as sleep and anxiety drugs because they are much safer to use. Benzodiazepines prolong rather than intensify the GABA response, which is what barbiturates did, and they have a much higher therapeutic index, meaning that the difference between the effective dose and the lethal dose is much broader with benzos than barbiturates. The only barbiturate that we really see prescribed in chronic pain care these days is Soma. So Soma compound is essentially a prodrug for meprobamate, which used to be marketed as Milltown, but virtually no one prescribes straight meprobamate anymore. But Soma, as you well know, is still used, and it is converted in the body to meprobamate, which is a barbiturate. It is a bad drug and it should be a high priority for tapering if you have any patients on that drug. So to go back to benzos, the first benzodiazepine approved was chlordiazepoxide, brand name Librium, which was approved in 1960. Diazepam or Valium was approved in 1963. From 1969 to 1982, Valium was indeed the most prescribed drug in America, as memorialized by the Rolling Stones in their song Mother's Little Helper. And some of you may know, some may not know, that Arthur Sackler of the famous Purdue opioid Sacklers began his career by making Valium a bestseller and honed some of the promotion techniques that they were able to use for OxyContin later. So in essence, benzodiazepines are effective and safe in the short term with rapid onset and good tolerability, but they have risks, as was recognized by the FDA in 2020 when they put a black box warning on the label for benzos, warning of serious risks of abuse, addiction, physical dependence, and withdrawal reactions. Next slide. So it is important to remember that benzos are FDA approved for short-term treatment of insomnia, not long-term. Same with the Z drug partial agonists, which include zolpidem, azopiclone, zaleplon, which are approved for the short-term treatment of insomnia. But in my practice, as I'm sure in many of your practices, many of the patients on Z drugs are taking them every day for months or years at a time. It is important to remember that benzodiazepines have no antidepressant action. They are not effective for PTSD and may harm. I'll talk more about that later. They don't work for obsessive compulsive disorder, another anxiety disorder. There are no long-term studies of use of these drugs in generalized anxiety disorder. And although alprazolam or Xanax is FDA approved for panic disorder, based on short-term studies, it has poor long-term results. Furthermore, benzodiazepines interfere with the exposure-based psychotherapies that are among our best treatments for anxiety. Furthermore, long-term benzo use is associated with amnesia, sedation, learning and motor impairment, motor vehicle accidents, falls, and fractures. There is an evolving literature about whether benzos are associated with dementia risk. It's a bit of a mixed story at this point, but I think the current evidence is that there is a dementia risk associated with long-term benzo use. So my slide has disappeared. Hopefully we can get my next slide up. There we go. So a bit about benzodiazepine pharmacoepidemiology. So about 5% of US adults use benzodiazepines. 1.6% of them are using both a benzo and an opioid. This is twice as common in women as in men. Both use and long-term use increases with age. So as you can see in the 18 to 35 group, we've got about 2.5% of benzo use, and about 15% of that is long-term. But if we switch up to the 65 to 80 group, now we're up to nearly 9% benzo use, and nearly a third of that is long-term. So for a decade, the Beers criteria of the American Geriatric Society that focuses on polypharmacy in older adults has made a strong recommendation based on high quality evidence to avoid all benzodiazepines in older adults. They're still popular. Next. This gives a sense of what's been happening. In recent years, the graph ends in 2014, but the trends have continued. MEPS prescription data and CDC death data show that between 96 and 2013, the percent of adults filling a benzo script went up from about 4 to 5.5%. The quantity prescribed went up from like 1 kilo to 5.5 kilos of lorazepam per 100,000 patients. Overdose death rate alarmingly increased by a factor of 6. And there was some plateauing in 2012 and 2013, but it started going back up in 2014 and has continued to do so. Next. It is estimated that 80% of unintentional opioid overdose deaths may involve benzos. Again, I think that's now decreasing with the lethality of fentanyl. Unfortunately, benzo prescribing is more likely when opioids are prescribed. So if you're going to get an opioid in an acute pain visit, that means you're 3 times more likely to get also a benzo. In chronic pain visits, if you get an opioid, then you're 4 times more likely to get a benzo. And that's because patients with chronic pain complain not only of pain, but insomnia and anxiety. So that's why sedative prescribing is more common with opioids. Even more common than getting a benzo or a Z drug is getting a muscle relaxant. And these are relatively mild sedatives, generally, the Robaxin, Flexeril, except for Soma, which I've already mentioned as a particularly bad and lethal drug that should be avoided. Next. So Anna Lemke, well known to the Oregon community, head of addiction psychiatry down at Stanford, wrote a very nice article in the New England Journal of 2018 about what she called our other prescription drug problem, meaning besides opioids. And she documented, again, this increasing rate of benzo prescription, the new black box warning, and added the clarification that the CDC and the FDA made to not avoid using buprenorphine in patients who are also on benzos. Because even though benzos add overdose risk to buprenorphine, it's still far safer to have patients on buprenorphine with their benzo than a regular full mu agonist opioid. All right, next. So it's important to remember, for those that may not be psychiatrists or in the middle of the psychiatric guidelines for anxiety disorders, is that both the American Psychiatric Association in the US and the National Institute of Health and Clinical Excellence in the UK recommend SSRIs, not benzodiazepines, for these anxiety disorders. They allow benzos to be used acutely to stabilize severely anxious patients, but they state they should not be used for more than 2 to 4 weeks. And anybody who has prescribed benzos for a short period of time knows that it can be quite difficult to stop prescribing them, and it can be a bit of a battle with patients. Benzos will cause physical dependency and may be difficult to discontinue. They are associated with sedation, fatigue, ataxia, blurred speech, memory impairment, and weakness, especially in the elderly. And benzo treatment may decrease patient motivation to engage in psychotherapeutic treatment like cognitive behavioral therapy. Next. So unfortunately, prescriptions of these anxiety medications increase the chance that they're going to be misused. A survey called NESARC, the National Epidemiologic Survey of Alcohol and Related Conditions, showed that the prescription of anxiety medications, specifically benzos, was associated with lifetime non-medical use, increased the rate at about 60%. Past year medical use, it basically doubled the risk, and it increased the risk of lifetime DSM-4 abuse or dependence by 2.5 times. And this was particularly likely in males, younger, white race, history of illicit drugs, history of other drug use disorders, or illegal behaviors. Next. There has been some debate in some quarters about the fact that opioids relieve anxiety disorders and should be considered for treatment. If you dissect into this, it's not as convincing as might initially appear to be the case. It is true that opioids often elevate mood in healthy subjects during acute use. They most specifically relieve anxiety. And in fact, the endogenous opioids like the endorphins and the enkephalins do mediate the effects of GABA, specifically benzo, and serotonin, 5-HT, SSRI drugs. So opioids are involved in the way that they work. And in fact, there's a very long tradition of using opioids to treat depression and anxiety that dates back to the Greeks with Hippocrates, the Romans with Galen. And in fact, the opioid treatment of both melancholia, meaning severe depression, and mania was popular and recommended in psychiatric textbooks through the 19th and into the 20th centuries. However, most modern studies of opioid therapy are uncontrolled case series. They're very weak. They do not provide strong evidence of an enduring and positive effect of opioids on either anxiety or depression. And yet, a number of studies clearly indicate that these patients are getting these drugs and staying on them. One of the most persuasive and famous was from Karen Seal and colleagues at UCSF, looking at 140,000 Iraq and Afghanistan veterans who had a pain diagnosis. Among those, she found that 6% of those without a mental health diagnosis got opioids. Those who had a non-PTSD diagnosis, 12% of them got opioids, so doubled. For those who had a PTSD diagnosis in addition to their chronic pain, 18% were receiving opioids, so that's a tripling of the rate of opioid use. Plus, these patients tended to get higher dose opioids, multiple opioids, concurrent sedative hypnotics, and also often got early refills on their opioids. Next. So pardon me for the fact this is a bit blurry. This is an article coming out and looking at, did the FDA black box warning about opioid and benzo prescribing do anything? And if I can direct your attention to the very last column, you'll see that across age and gender groups, there was a 15 to 20% decrease in concurrent benzo and opioid use. So it did make some difference. Not huge, 15% isn't that much, and it often is the less difficult patients on lower doses that get taken off in this kind of situation. But it proves that this was probably worth doing by the FDA. All right, next slide. So I'm going to focus a bit on a specific anxiety disorders. Most particularly, I'm going to talk about post-traumatic stress disorder. And this is the only psychiatric disorder that requires a particular kind of stressor, an overwhelming stressor that involves the fear of dying or other severe threat like a rape or an assault. And to just give you a thumbnail sketch of what this consists of, it consists of persistent re-experiencing of trauma, often in the form of nightmares or daytime flashbacks or just recurrent inescapable thoughts, persistent avoidance of reminders of the trauma, so people will stop driving or stop going to the part of the town where they were hit or attacked. There is a persistent increased arousal. Patients report being easily startled, having terrible insomnia, and having persistent irritability or anger. And finally, they often report persistent emotional numbing or withdrawal. They're just not really able to connect with other people or with their own feelings. And this is distinct from panic disorder, where you can have panic attacks with persistent concern and behavior change. But panic disorder is a little bit simpler and does not include necessarily an index trauma. Next. So we have used this screener. It's developed by the National Center for PTSD. This is actually the older version that we've published on, the 4-item version. There's now a new 5-item version appropriate for DSM-5, but either one is a useful tool. We use this in our pain center, and it's very quick, and it identifies quite a few of our patients as having PTSD or having symptoms that suggest that with a quick, easy screen. So it asks, have you had an experience that was so frightening, horrible, upsetting that in the past month you had nightmares about it or thought about it when you didn't want to? That's the re-experiencing criteria. Tried hard not to think about it or went out of your way to avoid situations that reminded you of it. That's the avoidance criterion. Were constantly on guard, watchful, or easily startled. That's the hyperarousal criterion. And finally, felt numb or detached from others' activities or your surroundings. So that's the emotional numbing criteria. Next slide. So let me kind of explain the relationship between PTSD and chronic pain, because it's kind of complicated. So patients with PTSD and chronic pain have both hyperresponsiveness. So that means that in experimental studies, they report higher pain ratings for suprathreshold noxious stimuli, like pinpricks or cold pressor or pressure tests. And this hyper-responsiveness is associated with anxiety sensitivity. The fact that this group are not only more anxious, but more sensitive to anxious symptoms and distressed by them. In addition to this hyper-responsiveness, though, patients with PTSD also have hyposensitivity, meaning that they show higher pain thresholds for both pressure and heat, meaning that it takes more noxious stimulus to get to the point that a patient reports it as painful. And this is associated with dissociation. So dissociation is often what happens when we face overwhelming trauma or threats. We, in essence, space out, go on a mental vacation. This is a really classic response of children to child abuse. They just kind of absent themselves or vacate themselves. Next slide. So the way I like to think about this is to divide PTSD into what I call hot and cold symptoms. And I borrowed this from one of my colleagues, Murray Raskin at the Seattle VA. So the hot symptoms are the re-experiencing symptoms, nightmares, flashbacks, and the hyperarousal symptoms like anxiety, anger, irritability, and insomnia. And these are thought to derive from the fight or flight response that mammals have to threats. You can notice this in your pets. But PTSD also includes what we call cold symptoms. So avoidance, people, situations, activities, and detachment from others, activities, and positive emotions. And this is thought to be a remnant of the even more primitive mammalian freeze response to threat. So if you, like when my dog lunges at a rabbit when we're out on a walk, that rabbit will often just freeze in place. And possums are famous for playing dead. And this is reflected in PTSD cold symptoms. So why is this relevant? Because opioids and benzos, I think you went backwards. If you could go forward one more slide. There you go. Opioids and benzos provide some relief from the hot symptoms, but they make the cold symptoms worse and prevent recovery from PTSD and probably prevent recovery from chronic pain. Next. So we looked at PTSD symptoms using a web-based online tracking tool that we use at the UW called Pain Tracker. And we found that the number of PTSD symptoms between 0 and 4, as on that questionnaire I showed you earlier, was significantly associated with all of the pain outcomes tracked in Pain Tracker. The effects were not limited to those who screened positive for PTSD, which is 3 or 4 out of 4 symptom domains. And it wasn't only anxiety, depression, and sleep that worsened with more PTSD symptoms, but things you wouldn't have thought as directly related, like pain intensity, pain interference, physical function, and opioid risk. And I pulled out a little bit of one of our tables out of this paper that shows number of PTSD symptoms in the top row and the percent that reported that. And then in this odds ratio of severe pain, that is how likely was this patient to report severe pain given the number of PTSD symptoms. So the reference group is 0, and you can see that the likelihood of severe pain report went up 10% in the group that had one PTSD kind of symptom, 70% in the group with 2, it doubled in the group with 3, and was more than doubled in the group with 4. The last row here looks at how likely was a patient to be considered high risk on the opioid risk tool according to their PTSD symptoms. So this went up even quicker and more dramatically than pain. So if you had one symptom, your risk of being high risk for opioids was doubled, 2.5 with 2 symptoms, over 3 with 3 symptoms, and nearly 4.5 with 4 symptoms. This is an indicator that PTSD affects many dimensions of chronic pain experience and care. Next slide. So, how do we understand anxiety? Is it an emotional reaction or, as I'm going to argue, a homeostatic emotion? It is certainly common to see anxiety in patients experiencing acute pain from an injury or a procedure, and the anxiety is seen as an emotional reaction to an aversive sensation or sensory experience. That idea is also extended to chronic pain. We often hear from both patients and providers in clinical settings that anxiety is a reasonable emotional reaction to the pain experience. And in fact, patients like this because it destigmatizes their emotional response. But it sees anxiety as only an effect of pain and not a cause. It isn't consistent with the most recent neuroscience because it ignores the fact that we're seeing overlapping brain sites activated by pain and anxiety. And an alternative theory that I have found useful is to consider pain a protective. It protects homeostasis emotion so that pain, anxiety, and depression form a continuum of protective emotional states responding to threats to bodily and personal integrity. And there's a host of investigators that have made this argument, from Bud Craig to Antonio Damasio and to Baliki and Abkarian, who are at Northwestern University. Next. So to get practical about addressing anxiety disorders, and antidepressants, not benzos, are the treatment of choice for anxiety disorders. However, anybody who's used antidepressants in patients with anxiety disorders knows that antidepressants can worsen anxiety early in the course of treatment. That can be prevented by starting your traditional SSRI type antidepressants at low or very low starting doses, rather than, for example, the 20 milligram of citalopram or Celexa that would be standard. You can start at 10 or even 5 milligrams. Another strategy that you can use is antidepressants with a blocking action at the presynaptic 5-HT2 receptor. So SSRIs basically keep serotonin in the synapse in an active form for longer action. And this helps postsynaptically, but it also activates this 5-HT2 presynaptic receptor, making the patient anxious. Luckily, there are commonly used drugs that block that receptor and tend to minimize this anxiety. Tricyclics, we use nortriptyline. Nefazodone, which is a drug similar to trazodone, mirtazapine, and trazodone itself all do this. One other way of working around this is if a patient is already on a benzo, you initiate the antidepressant before tapering the benzodiazepines. I rarely use benzodiazepines to help start patients on antidepressants, but it can be done. Then the benzo taper can be a bit of a challenge later. Next. So apologize for this being a kind of a busy slide. But one tool that I have found very useful in the patients that I see with PTSD at the UW Pain Center, and I certainly see a lot of them, is an old antihypertensive drug called Prasasin. It's a centrally acting alpha-1 adrenergic receptor antagonist that was marketed for the treatment of depression as Minipress. It's not used much for that anymore. It is not a drug of abuse. It's not addictive. It's not a controlled substance. And it doesn't interfere with psychotherapeutic treatment of PTSD. In fact, it may promote it. It has been proven effective in multiple small trials, active duty soldiers, civilians, and it specifically reduces the hot symptoms, namely the nightmares and the hyperarousal symptoms. It is more effective over the long term than quetiapine. It is often seen that PTSD patients have very refractory insomnia, and they get placed on the antipsychotic quetiapine, the brand name Seroquel, and they were both equal in short-term effectiveness, but the Prasasin had fewer discontinuations and worked better over the long term. I typically will start patients at 2 milligrams at bedtime. You do need to warn the patient about dizziness and orthostatic hypotension. About the only side effect that Prasasin has is dizziness and hypotension. And for that reason, we need to gradually increase. For more frail or geriatric patients, I start at 1 milligram at bedtime. And I often engage one of our clinic pharmacists to help with dose titration. One nice thing about Prasasin is that patients accommodate to a dose within a period of a week, and so you can increase the dose weekly rather than monthly like lots of other psychotropic meds. Prasasin is very useful at settling things down so that you can move on benzo taper or initiating other psychotropic medicines like SNRIs that the patient may previously have not been able to tolerate. Next. And as I mentioned, Prasasin also can make psychotherapies easier to tolerate by lowering the hyperarousal. And these really, in my mind, remain the definitive treatments, particularly for PTSD, but for a wide variety of anxiety disorders. And these psychotherapies can vary from quite simple relaxation training through biofeedback using measures of autonomic state to kind of guide relaxation, mindfulness training, which often uses breath awareness to focus on the present rather than fearful cognitions, self-hypnosis using imagery. Cognitive behavioral therapy has been shown to be effective in a wide variety of anxiety disorders, including panic, GAD, post-traumatic stress disorder, obsessive compulsive disorder, and social anxiety. Acceptance and commitment therapy is a cousin of CBT, employing some of the same techniques, but more focused on investment in valued activities than specifically dysfunctional cognitions and coping. For patients with PTSD, there are a variety of well-proven trauma-focused therapies, including prolonged exposure, cognitive processing therapy, that can be a valuable component of addressing chronic pain. And for patients who have multi-layered trauma, perhaps they had childhood abuse, and then they may have had an abusive spouse, had an accident, and so there isn't one specific trauma to focus on in therapy. A more broad-based coping training therapy, such as dialectical behavior therapy, could be appropriate. All of these therapies provide for skill development and avoid medication dependence and withdrawal problems. Next. So what about Robert, the patient that I mentioned at the beginning of this talk, the 49-year-old with chronic headache, neck, and low back pain? Remember that he was taking 40 milligrams of oxycodone and 2 milligrams of clonazepam, which he was very reluctant to taper because he considers it essential for his survival and stability. And perhaps not surprising, he scored 4 out of 4 on his PTSD screener. Nobody had really ever talked to him about PTSD before. We started him on Prasasin, 2 milligrams at bedtime to address his nightmares and hyperarousal, and increased that by a titration of 2 milligrams per week. He required 8 milligrams before his nightmares were stopped. And with his sleep greatly improved, he became more open to considering and reducing his clonazepam dose. It was also necessary to address anxiety and depression in him more further than the Prasasin. And in fact, we ended up adding a low-dose tricyclic, some nortriptyline. He may need to transition to buprenorphine rather than taper. A number of these patients, the dual benzo and opioid users, don't tolerate full opioid taper very well, but they can be switched to a safer regimen using buprenorphine or Suboxone. Next slide. So in conclusion, benzodiazepines are a seductive because they're effective in the short term, but risky treatment for anxiety. They are quickly effective with few initial side effects like opioids, but over time, therapeutic effects lessen, side effects increase with amnesia, concentration, lethargy, and dependence. These drugs also impede the effectiveness of psychotherapies. And important for safety is to remember that benzos multiply opioid overdose risks significantly, and there is no safe combined opioid benzo regimen. The thing to do is to get the patient off one or the other drug. Antidepressants are the treatment of choice for anxiety disorders, but can cause anxiety worsening initially. This can be addressed with low initial doses and choosing antidepressants with blockade of that presynaptic 5-HT2 receptor. Prasasin is an old drug, but is effective for PTSD nightmares and hyperarousal and may facilitate the use of other psychotropic and chronic pain treatments. Finally, there are multiple psychotherapies proven to work with anxiety disorders, and these treatments provide patients skills they can use after any medication treatment is complete. So that's the end of my comments. I'm happy to answer any questions that you might have. So I can't hear you, Ian. I don't know if other people can.
Well, no, because if you don't turn your microphone on, then nobody can hear you. It's one of those crazy things. Hey, thank you, Dr. Sullivan, on behalf of everyone. And I don't know if you're able to see the chat. There are a few questions that have already come that people are just asking.
On private chat, but let me see. Oh, okay. Yeah, I see some. And how should I go through them?
So if you, oh, that's a great question. I know that.
Should I start with the most recent ones?
Yeah, that sounds great. And then I just want to tell you, I'm going to sit right over here. And if you want, I can watch this as you talk, just so you don't have to do both. Or if you want to do both, that's fine as well.
All right. Well, I'll try to make my way through these. So Karyi Wu asked me suggestions on how to manage the orthostasis of Prasasin even at 1 milligram a night. So there are people who will, even at the starting dose, have significant dizziness and orthostasis. I see a fair number of patients, particularly the ones with severe trauma, who have what's called POTS, postural orthostatic tachycardia syndrome, and the neurologists can treat that sometimes with beta blockers, which makes Prasasin use pretty hard. What I do is sometimes I'll drop people back to a 0.5 milligram. It's also possible to switch them to other alpha blockers, which are now largely marketed for prostate problems. Doxazosin, Prasasin, I use, and they are slightly less lipophilic, don't get into the brain as quickly, and might be easier to tolerate than the Prasasin. So that's one idea. Katie Snyder asked, do you use Prasasin even if no nightmare symptoms? And if so, how do you know when you are at the appropriate dose? So the most responsive PTSD symptom to Prasasin is nightmares. And it's quite interesting that many patients will report their nightmares become less violent before they actually disappear in the face of Prasasin treatment. So although nightmares are the most responsive symptom, hyperarousal and treatment-resistant anxiety in general can respond to Prasasin. And I will use Prasasin in people without nightmares if they have prominent hyperarousal symptoms. And so if that's what they have, then that's how you have to track what's the right dose, you know, how are their symptoms responding, how bad is their side effects. We don't have good data on Mark Stevens is asking about data for 20 and 21, and national data just isn't out, hasn't been analyzed. But the signs are that virtually all substance abuse has gotten worse in the midst of the COVID pandemic. So I can't imagine that it's better. Paul Quello asked me to comment on the use of Buspirone as an anxiolytic. So Buspirone was marketed in the 1970s, brand name Buspar. It is a presynaptically active serotonin drug. When I was trained, the lore on Buspar was that the good news was it had very few side effects, and the bad news was that it had very few therapeutic effects. So the reputation in psychiatry is that Buspirone is a pretty weak drug. It got a second lease on life from the STAR-D trial, which was a multi-stage randomization trial of antidepressants and augmenting strategies, and Buspar was one of the antidepressant augmentation strategies used in the STAR-D trial, and it did work for some patients. So it has gotten a second lease on life as something that augments other antidepressants. The other thing that's changed for Buspar is we probably were underdosing it significantly in the 70s and 80s. And rather than doses of 10, 20, 30 milligrams a day, we probably have to use doses at least twice that high. I mean, one nice thing about the drug is it's well tolerated. One unfortunate fact about Buspar is that virtually no patients who like their benzodiazepines are going to be happy with Buspar. It does not really produce the same dramatic relief that something like Xanax or even Klonopin does. So people were hoping, oh, great, I'll get people off benzos and put them on Buspar. That alone has not been very successful. Tom Quello asked me to comment on Traumadoll. Traumadoll is a very interesting drug. It came over from Germany and was thought to be a pain reliever, an analgesic that was more potent than Tylenol or NSAIDs, but non-addictive. In subsequent years, it has become clear that it is a mu agonist. It does function as an opioid. It is addictive. It can produce dependence, and in fact is now a controlled substance. It is a weak opioid, so it is less dangerous than oxycodone or even hydrocodone, but it is not free of opioid risks, including respiratory depression. So any data on deaths having both benzos and alcohol? Laurel Hansen asked that. That is a potentially lethal combination, even without opioids. You can kill yourself with a benzo overdose combined with drinking. I don't have those numbers with me at the moment. In a pain context, also, opioids tend to be also included, which magnify the lethality of benzos and opioids. Okay, I think those are the main questions in the chat. I don't know if there are anything else.
No, well, Dr. Sullivan, yeah, you're I think you're keep very Katie one question, and then Dr. Sullivan, I was also going to say you are, of course, right on time. You are staying very nicely on our schedule, and I was going to offer you and everyone, if you wanted to answer Katie's question, and then I don't know if you want a 2-minute personal break, or if others need that moment before, because you've been so gracious to do 2 back-to-back talks.
Yeah, Katie Snyder wants to know if the increase in anxiety with the SSRIs is temporary. And I would say yes, usually. Usually you can wait it out. It's a process that kind of habituates itself. It depends how severe the anxiety is, and it can be pretty hard to get past, particularly in people with severe PTSD, which is why I suggested other strategies other than just waiting it out.
And again, thank you, Dr. Sullivan, for your previous talk and for being willing to do 2 that are obviously sort of a match set. And I'm going to just turn it back over to you. But one comment you made in your previous talk that sort of stood out was, and I hope you won't mind, and you can tell me if I'm quoting you inaccurately, but you said, I think, that benzos and opioids probably prevent recovery from chronic pain, which is seems like that's a seemingly big statement, and maybe leads into some of what you're going to say. So I'm going to step off stage, but Dr. Sullivan, if at any point we can be of any assistance, if I can help, please just let me know.
Sure.
So thanks.
Thank you, Ian. So can we pull up my first slide? So I was asked to talk about non-opioid chronic pain relievers, non-opioid analgesics, and specifically how to use these in a stepped care strategy, which is a structured, stepwise strategy to chronic pain care. So I'm going to talk not so much about pharmacology, but kind of about structuring care in terms of what goals to have for care and how to make sure that those goals are met. So next slide. This is the agenda for my talk. As I mentioned, we're going to talk about goals of chronic pain therapy, specifically pain relief and what one of my colleagues calls the pain reduction regime, and basically goals and measurements of that. I'm going to talk a bit about how those goals apply to the 3 basic types of chronic pain as defined by IASP, the International Association for the Study of Pain. And then I'm going to go through a number of randomized trials of stepped care strategies for chronic pain to see what we might be able to learn about what works. Trials that were largely completed in the first half of the 2010s. All right, next slide. So here's a case of somebody that we'll keep in mind throughout the talk. Suzanne is a 36-year-old woman with chronic abdominal pain. Her abdominal pain started at age 29, 7 years previously, and her diagnosis at that point was diverticulosis with an abscess. So she had little outpouchings from her sigmoid colon that became infected, and the treatment that she received at that time was a removal of part of her sigmoid colon with significant pain relief. However, some years later, she was stabbed in her right lower quadrant in the area that she had her previous pain by an unknown man outside her apartment. She only suffered a superficial abdominal wound. It did not go through her abdominal wall. She did not get a bowel injury. She had bruises, but it was very psychologically traumatic. And now, some months after her stabbing, she reports 8 out of 10 abdominal pain despite 40 milligrams of oxycodone per day. The background of her life situation is that she has been currently going through a difficult divorce. She, in the past year, had a loss of a pregnancy, a falling out with her husband, and was now proceeding with a divorce. And there was some concern that her husband had tried to take revenge on her, either by stabbing her himself or hiring somebody to do that. Her screen for PTSD was 4 out of 4 positive. Interestingly, she denied that she had been through earlier significant trauma, but had basically no memory of her high school years during which her parents went through a difficult divorce. And this lack of memory can be a sign of a difficult period where there was dissociation, and that's why the memories just didn't form. All right, so keep Suzanne in mind as we go through some of this other material. Next. So when we think about the goals of chronic pain therapy, lots are possible and desirable, but perhaps not attainable. So patients who come to physicians or other healthcare providers with chronic pain would love to have a cure. They would love to be just relieved of their pain problem. Boom, here's a treatment. Just like I'm going to treat your pneumonia, I'm going to treat your chronic back pain, I'm going to cure it. Boom. There is certainly a lot of advertising in newspapers for minimally invasive surgery or other procedures that promise a cure of back pain. I'm not going to get into that, but it's not often possible with the patients that we see. Sometimes patients are just saying, I want to know what the cause of my pain is. I would love for you to remove it, but at least you could tell me what the cause is. And we come up with all sorts of different explanations for chronic back pain, from muscle strain to facet joint problems to spinal stenosis and slip discs, and a lot of these diagnoses are neither relevant nor valid and often are not that helpful to the patients with chronic pain. So if we're unable to diagnose and remove the cause of pain, then patients would like to have their pain relieved. Ideally, no pain. If you can't remove the cause of my back pain, well, then just remove the pain. Zero pain is not often obtainable. It's certainly not obtainable with analgesics without rendering the patient dysfunctional from sedation. Although some patients will be satisfied with less pain. They say that would make me happier, that would let me do more things, and we'll talk about less pain as a goal in more detail in a minute. Even if pain relief is not possible, then at least we can help patients with pain management. At least that's the argument by the professional pain community. Although one must ask, pain management with what tools? Are you talking about other pills? Are you talking about exercises? Are you talking about psychotherapy, physical therapy, acupuncture, massage, chiropractic care? So what tools aimed at what goals? Are you talking about symptom reduction, function improvement, quality of life enhancement? And let's say that we are focused on quality of life. This entails other questions like quality of life as defined by whom? Sometimes workers' comp programs think improved function is really the appropriate goal for chronic pain care. But what function is most relevant? Is that physical function, social function, emotional function, cognitive function? And what constitutes the right standard for quality of life? Sometimes we'll focus on a broad sense of improved health, less disease, less symptoms, or something positive like increased capabilities for pursuing the life you want. So let's keep those in mind as we go through some more concrete options. Next slide. So pain care in recent decades, maybe forever, but particularly in recent decades, has been dominated by the goal of pain intensity reduction. So it's helpful to look at a bit of history about this. So pain intensity assessment was originally done with what was called a visual analog scale. And it was a simple 100 millimeter, not centimeter, 100 millimeter line. And the idea was that the patient was supposed to draw another line crossing that line to show how intense their pain was. Scientifically, this was great because the scale was proportional to the pain and actually proportional to the noxious stimulant. Don Price was an investigator originally in Virginia, then in Florida, who worked in the domain of psychophysics to quantify the relationship between noxious stimulus intensity and experienced pain intensity. And in fact, he was able to derive mathematical formulas that detailed how pain increased as an experimental pressure or heat pain stimulus increased. That approach to assessing pain was borrowed and adapted for clinical use in the form of a numerical rating scale, which I have a little picture of a common form of that here. It's, I'm sure, going to be familiar to all of you. It was originally adapted for use in cancer pain treatment, most notably in the brief pain inventory developed by Charles Cleland. And they assess pain now, worst pain, least pain, etc. But the focus is on what intensity of pain are you currently treating. In cancer pain care, this method of assessing pain was married to a strategy for dosing opioids called titrate to effect. And some of the real cancer pain pioneers like Kathy Foley and Russ Portnoy at Sloan Kettering Memorial Hospital in New York pioneered this idea that unlike many other drugs and even some analgesics like aspirin and Tylenol, there is no a priori correct opioid dose when you're treating cancer pain patients. The right dose is the dose that relieves pain. And the way that pain relief was understood was lowering the pain intensity level. If you're able to lower a pain score from a 9 to a 5 or an 8 to a 4, you've done something significant and you are achieving what the goal was with opioid therapy. Next. So this approach has an interesting history. As I mentioned, the notion that the 0 to 10 pain intensity score is the best measure of the need for pain treatment and the best measure of the success of pain treatment arose in the treatment of cancer pain and spread to the treatment of chronic non-cancer pain. In fact, back in 1996, the American Pain Society, the premier pain research organization in the US, introduced the idea of pain as the 5th vital sign. So the idea here was that if we assessed pain like other vital signs such as blood pressure, temperature, pulse, it would increase the visibility of pain, which often is invisible. Other health systems like the US VA by 1998 enacted a national strategy to improve pain management that required providers to assess a patient's pain intensity as measured on a 0 to 10 numeric rating scale and record this in their electronic medical record. By 2000, the Joint Commission, the accrediting body for healthcare organizations, issued standards for pain management that encouraged organizations to use quantitative measures of pain. By pain assessment was occurring in over 90% of the clinical encounters across the VA. Unfortunately,
hi everyone. These are technical difficulties. I am sure that Dr. Sullivan is quickly re-engaging with his computer.
Sorry, I didn't realize I had disappeared. So can we get back to the slide I was on? All right. So as I mentioned, patients and providers assume that pain must be reduced first for a patient with chronic pain to improve and recover. Patients claim pain is the reason that I am anxious or depressed. It's the reason that I have functional impairments and insomnia. And if I'm going to get better, you need to reduce my pain. And so we actually looked at that using our pain tracker data at the University of Washington Pain Center. We assessed 666 patients with chronic pain, and we specifically looked at ones who had demonstrated an improvement in pain intensity, at least 1 point on a 0 to 10 numeric rating scale over a 1-year period. And we found that decreased difficulties with sleep initiation, with depressive and anxious symptoms and disability actually predicted later improvement in pain intensity, whereas pain intensity was really a predictor only of improvements in sleep initiation and maintenance. So our results indicated that reductions in pain intensity may not be the first factors to change in effective chronic pain management. It's not the only way to proceed to reduce pain before you can make the patient better. Next slide. So there are other reasons to think that reduction in pain intensity may be neither necessary nor sufficient for improvement of the patient. A couple things that suggest that pain intensity reduction is not necessary is that most effective and commonly used chronic pain pharmacotherapies, specifically the drugs that are approved for chronic pain treatment like duloxetine and pregabalin, as well as psychotherapeutic and rehabilitation efforts like multidisciplinary pain rehab, really produced quite modest mean pain reductions. In general, about 1 out of 10 points on the numerical rating scale. And despite this relatively modest pain intensity reduction, these treatments work. Furthermore, there are pain treatments, effective pain treatments like mindfulness training and acceptance and commitment pain therapies that don't just strive for pain intensity reduction at all, but are proven to produce therapeutic benefit. Furthermore, pain intensity reduction may not be sufficient for the patient to improve. Aggressive titration of opioid therapy to keep pain intensity minimized often, maybe usually, results in decreased physical and role function and quality of life. I mean, if all you're trying to do is minimize pain intensity without paying attention to what other effects your treatments are having on the patient, you can end up with a very sedated and dysfunctional patient. Somewhat jokingly, we sometimes refer to the metric of couch time. If your treatment for chronic pain is lowering the patient's pain level, but increasing the number of hours per day they spend on their couch, you are not succeeding. It is interesting that even patients with advanced cancer often opt for less than complete pain relief, given free access to opioids, in order to preserve other things that are important and meaningful to them, like being able to think and remember and converse and have meaningful interpersonal interactions with their family and friends. So there are other things relevant to patients' quality of life beyond pain. Next. All right, so let me switch to talking about the 3 basic types of chronic pain according to IASP, the International Association for the Study of Pain. And those 3 types are nociceptive, neuropathic, and nociplastic. So nociceptive pain is mostly what acute pain is. That's pain with a clear source in damage or injury. And it's defined as pain that arises from actual or threatened damage to non-neural tissue and is due to the activation of specific receptors called nociceptors. This is different than neuropathic pain, which is defined as pain in the area of a neurologic sensory deficit. So somebody will be hurting in an area that they otherwise say they're numb. And there's 2 main types of neuropathic pain. Peripheral, that is pain caused by a lesion or disease of the peripheral somatosensory nervous system, and central neuropathic pain, pain caused by a lesion or disease of the central somatosensory system. So common causes of peripheral neuropathy are diabetes, alcohol, sciatica, small fiber neuropathy. Central neuropathic pain comes from things like spinal cord injury, strokes, multiple sclerosis are all common causes of central neuropathic pain. Finally, there's nociplastic pain that is defined as pain that arises from altered nociception. And this is pain that used to be called functional or psychosomatic or exaggerated, but it actually is quite a common form of pain, and it is most classically found in fibromyalgia, for example, where there's no obvious peripheral generator for pain, but a set of brain-based mechanisms that increase sensitivity to noxious stimuli. So in nociplastic pain, there's no clear evidence of actual or threatened tissue damage causing the activation of peripheral nociceptors, and no evidence of disease or lesion in the somatosensory system like you would find in neuropathic pain. So how do we relieve these? Next slide. So nociceptive. There isn't a lot of purely nociceptive chronic pain, but one classic example is osteoarthritis, involving age-related degeneration of the cartilage in your joints, leading to, as patients often say, bone on bone in my knees or my hip. So how might we address this pain? We might actually reduce the nociception, and one well-proven effective treatment for severe osteoarthritis is joint replacement, which stops the peripheral input. There are other treatments like injections of hyaluronic acid that it provides a temporary replacement for cartilage that has some value, although a lot of attempts to reduce nociception, most notably through arthroscopic snipping and clipping of meniscal fragments or other degenerative changes, has not been shown to be superior to placebo. Osteoarthritis is generally considered to not be an inflammatory condition, but there are secondary inflammatory phenomena, and so people do get steroid injections, epidural steroids, intra-articular steroids in this situation, and even non-steroidals are thought to operate partially by reducing inflammation. There is a role, even in this peripherally generated set of pain problems, in reducing central sensitization. And both antidepressants and anticonvulsants have some evidence of helping in these chronic pain conditions. Next. So neuropathic pain, we luckily have disease-modifying drugs in diseases like MS. That's new. And there are a wide variety of them: interferons, glatiramer, monoclonal antibodies. A variety of drugs now help reduce the autoimmune damage to myelin and the axons in MS. Controlling diabetes tends to retard the progression of neuropathic pain, although it doesn't treat the pain or reverse the damage. Pain-reducing drugs would now consist of drugs that affect neurotransmission, like anticonvulsants and antidepressants, and rehabilitative strategies like remobilization or assistive devices can also relieve the effects, if not necessarily the experience, of neuropathic pain. Next. So nociplastic pain has been defined more thoroughly using functional neuroimaging like fMRIs, and there are not a lot of treatments with a strong evidence base here. Tricyclic and SNRI antidepressants work, as do anticonvulsants, the modern calcium channel blockers, the gabapentinoids, but also the more traditional sodium channel blockers like Tegretol and Depakote. Next slide. So interestingly, the National Institute of Clinical Excellence, which is a central evidence synthesizing body in the UK, recently reviewed evidence for the treatments for the new diagnosis of ICD-11 chronic primary pain. And this is defined as a pain syndromes not better explained by other illnesses. So it's not a secondary pain syndrome, it's a primary pain syndrome. And although they don't call it nociplastic, it is essentially nociplastic pain. And NICE, in their evidence review, recommended 1, exercise programs and physical activity, known to be helpful in fibromyalgia. Psychological therapies they recommended, specifically cognitive behavioral therapy and acceptance and commitment therapy. They recommended acupuncture or dry needling, but no therapies directed at brain disease or the abnormalities that have been identified on functional neuroimaging were recommended. The only pharmacological treatments recommended were antidepressants. And in fact, specific recommendations were made against the use of anti-epileptic drugs, including the gabapentinoids, local anesthetics, ketamine, opioids, NSAIDs, and others. I don't know the details of how they analyzed the gabapentinoid data because there are some trials suggesting gabapentin works in fibromyalgia, but it's a more mixed bag than you would maybe think. Next slide. So now what I want to look at is how has stepped care been used to treat chronic pain? Specifically, what has been seen in randomized controlled trials of stepped care interventions. And these are interventions that use a care team and an algorithm to address chronic pain. Not a simple medication trial, but a care system or a care approach. The first model of stepped care for chronic pain was directed by Kurt Kroenke and was published in JAMA in 2009. Kurt Kroenke is an internist at the Regenstrief Institute at Indiana University in Indianapolis. So they randomized 250 patients with musculoskeletal pain and depression to first 12 weeks of optimized antidepressant therapy, then 6 sessions of pain self-management program over 12 weeks, that was step 2, and then a step 3, which was a continuation phase of relapse prevention for an additional 6 months. What they found is that 36% of intervention subjects compared to 16% of control subjects had a 50% or greater reduction in depression. 41% of the intervention compared to 16% of controls had a greater than 30% reduction in pain. And 26% of the intervention group, as opposed to 8% of the control group, achieved both endpoints. The intervention group, when you look what they got more antidepressants, more switching between antidepressants, and more algorithm-directed medication adjustments than the control group. So it's important to see that you're getting a significant improvement in treatment efficacy here, intervention compared to control, but this is not 100% pain relief. This is not 100% depression relief. Not everybody is responding. There are still people who do not get better, but you are clearly improving significantly on usual care. Next slide. Another trial published in 2009, Steve Dobsha from OHSU directed this trial. I actually helped a little bit with this, the CCAP trial. In this trial, 401 veterans with moderate or worse musculoskeletal pain, largely spinal or extremity pain, plus disability for at least 12 plus weeks or 3 months, were randomized. The intervention consisted of 2 sessions of education for the clinicians, and then patient assessment by a care manager, followed by education, activation, symptom monitoring, and feedback. So it was a structured effort to educate patients, frankly, to de-emphasize efforts to lower pain scores. And increased efforts on improving function and mood. The result was greater improvement on a standard Roland-Morris disability measure, pain intensity, and depression. This trial showed less improvement than the Krunke and other similar trials, but this population was more severe and chronic than the ones that had been seen in other trials. When you looked back and tried to define what treatments did the intervention group get, they did get more adjunctive pain meds and actually some more long-term opioids in the intervention group, although not a lot of them got opioids. Next slide. You went 2 slides. Go back 1, please. There we go. So an interesting stepped care trial was published in 2011 from a group at Keele University in the UK. It was called the Start Back trial. And what it did was stratify care for low back pain to limit the use of unneeded, ineffective care. It's long been recognized that many patients with back pain get better on their own, and they really don't need extensive or intensive medical care. And in fact, you may harm patients by imaging them and getting them engaged in the medical system when in fact they would get better on their own. On the other hand, some patients are very disabled, have quite a chronic course, and this idea gave rise to the Start Back trial of trying to find an efficient way to sort out the patients who are going to do well with minimal treatment and those who need more extensive treatment. So Start Back was a trial of stratified care for low back pain. 851 patients were randomized to intervention 2-to-1 with controls. They were stratified into low, medium, and high risk groups using a tool assessing 9 items, and it took less than a minute to complete this tool, concerning pain, disability, and distress. It asked, how severe your pain was, whether you had like sciatica with your back pain, and how distressed you were, including whether you were catastrophizing or very fearful of movement. Low-risk patients scored 0 to 3. The high-risk patients scored highly, specifically 4 to 5 on the distress items, and the middle group was all considered medium risk. So the intervention for the low-risk patients was just a 15-minute video and a back book, basically a self-care instruction. The medium risk group got that plus standard physical therapy, which was focused on physical symptoms and physical function to get people moving again. The high-risk group got the instruction on self-care, got the standard PT, but they also got psychologically informed physical therapy to address their high distress levels and their fear of moving. The control group got basic physical therapy, and that could be increased at the discretion of the physical therapist. Next slide. So the results of the trial showed that the disability, again, the Roland-Morris scale, improved more in the intervention group, both at 4 and 12 months. The effect sizes were 0.3 at 4 months, 0.2 at 12 months, but significant. Furthermore, broad-based intervention effects on health status, specifically quality adjusted life years, and importantly, costs, showed advantages to the intervention group. And in fact, the Start Back intervention was projected to be a cost-effective strategy for low back pain over 10 years. Next. So there have been some additional step care trials in more recent years. Kurt Krunke did another trial 5 years after his previous trial. This one was called SCOPE, or Stepped Care to Optimize Pain Care Effectiveness. And this was a telephone delivered rather than an in-person collaborative care management intervention comparing that with usual care in 250 patients with chronic musculoskeletal, at least moderate pain, meaning their BPI pain score was at least 5, from 5 primary care VA clinics. And this group had some psychiatric comorbidity. 25% of them had major depression, 16% had PTSD, and about a third of them were on opioids. The intervention was 12 months of telecare pain management with auto symptom monitoring and algorithm-guided analgesics. Now, it's important to realize that the symptom monitoring was more broad-based than your classic pain intensity measure. For their pain measure, they used the PEG scale, which is a 3-item scale that does ask on 0 to 10 scales. The P is the pain and severity. E has to do with how much is pain interfering with your enjoyment of life. It's a rough mental health measure. G is how much is your pain interfering with your general activities. And Erin Krebs, one of Kurt's trainees and now an accomplished investigator herself up in Minneapolis, showed that virtually all of the informative variants from the brief pain inventory in primary care settings could be captured by the simple 3-item measure called the PEG. That was used combined with the PHQ-4, which is a short 4-item measure that takes 2 of the core depression assessments from the PHQ-9 and 2 of the core anxiety assessments from the GAD-7 and puts them into a brief screening measure. It's important to remember that Kurt Kroenke, although he's an internist, he's been very interested in depression in general medical settings forever, and he was actually the developer of both the PHQ-9 and the GAD-7. So he used those in this trial and worked through an algorithm starting with what were considered to be the treatments with the best risk-benefit ratio, acetaminophen and nonsteroidals, followed, if those did not work, by tricyclic antidepressants and cyclobenzaprine, followed by Traumadoll, gabapentinoids, topical analgesics, and finally opioids. The result was the intervention group had a 1-point lower BPI score at 12 months and were nearly twice as likely to report at least a 30% improvement in the pain score. So their number needed to treat was 4 to produce a 30% improvement in pain score. The brief pain inventory pain interference score also improved, as did measures of global pain improvement and treatment satisfactions. Few patients in either the intervention group or the control group required opioid initiation or dose escalation. Next. And this will be the final stepped care trial I'm going to review. It was directed by Matt Baer, who is another one of Kurt Kroenke's proteges. This was called the ESCAPE trial, the evaluation of stepped care for chronic pain in Iraq and Afghanistan vets. It randomized 241 veterans with chronic, meaning more than 3 months, disabling, musculoskeletal, spinal, or extremity pain to intervention or control. The intervention was 12 weeks of analgesic optimization by algorithm combined with pain self-management, followed by 12 weeks of cognitive behavioral therapy delivered by nurse care managers. By 9 months, disability, again by the Roland Morris, had decreased 1.7 points in the control versus 3.7 points in the intervention group, about a doubling of the effect. Brief pain interference decreased by 0.9 in the control and 1.7 in the intervention group, again about a doubling of effect, and the graded chronic pain scale decreased by 4.5 points in the control group and 11.1 in the intervention patients. The average patient was about age 37. 60% of these patients were employed, and they had moderate levels of both depression and PTSD. Next. So, what are the common elements of successful stepped care interventions? First of all, and most importantly, these interventions support self-management and don't try to replace it. The patient has to participate in the care and in taking care of themselves. Just like other chronic diseases like diabetes, you cannot manage the illness from the office alone. Most of the time, the patient is managing their illness themselves, and we need to empower and instruct the patients about how to do that. Reactivation through physical therapy and/or cognitive behavioral therapy, it was included in all the successful interventions. Patients have to be supported, encouraged, and helped to resume life activities. Attention to distress, depression, anxiety, and PTSD was present in all interventions. So these were not simply pain-focused interventions. They were quite attentive to the psychiatric comorbidity common in chronic pain. Finally, management was proactive and measurement-driven, not reactive. So there was a tracking, not only of pain and its effects, but other issues like depression and anxiety, to make sure that these did not get out of hand, that they were improving, that treatment was adjusted to produce improvement. Finally, analgesics were prioritized by evidence of benefit and lack of harm. There was, in general, an avoidance of controlled substances. Not a complete prohibition of them, but definitely an avoidance. And all of this was implemented by a team. Not exactly the extensive team that you might have in a specialized pain clinic, but the kind of team that actually is present in many chronic pain or primary care settings. Nurses, social workers, a nurse care manager, and a consulting specialist using technology to support symptom monitoring and treatment algorithms. Next slide. So, back to Suzanne, our 36-year-old with abdominal pain. Remember, she reported 8 to 10 abdominal pain despite 40 milligrams of oxycodone per day. And she was going through a difficult divorce. There was some question of whether her husband had tried to attack her or gotten somebody to do that. She also screened 4 out of 4 on her PTSD, and she denied earlier trauma but didn't have any memory of her high school years. Next. So it's important to recognize in cases like Suzanne that physical and psychological trauma are relevant to chronic pain problems, and healing must address both. So she had had a previous sigmoid illness. She had diverticulitis and needed a sigmoid resection. And then this other time, she had relatively minor physical trauma, no penetration of her abdominal wall, just some bruising, but that reactivated her pain problem in a quite severe and disabling way. So opioids are favored by patients with pain and PTSD. They calm the hyperactivity and they settle down insomnia problems, but because they worsen avoidance and withdrawal, they prolong PTSD. Prasasin, which I discussed in my last talk, can help opioid taper and may, although a transition to buprenorphine may be necessary. Avoiding benzos is important. It's not good for pain or PTSD. TCAs or SNRIs may be helpful. A gabapentinoid may be necessary. Next. So, what conclusions about analgesics and stepped care? First of all, reactivation, both physical and social, are more important in chronic pain recovery than analgesia. That may actually come from physical and social reactivation. Once good things are happening in your life, the salience of pain may decrease. Opioid analgesia, aggressively trying to lower pain scores, may reduce pain and retard reactivation. There are non-opioid analgesics, antidepressants, and anticonvulsants specifically that may help promote reactivation. Proactive and measurement-based care keeps longer-term goals in sight and lessens distractions by crises and pain flares. When you're talking about chronic pain, medical care focused on removing pain generators and lowering pain levels is rarely adequate, especially with complex, high-impact chronic pain. So that's the end of my talk, and I'm happy to take some questions. Let me switch over to the comments here. I'll work my way backwards through the questions. So Cindy Armstrong asks about your thoughts on gabapentin when somebody is in a long-term MAT program, specifically methadone. So gabapentin is a very mixed bag in my view. I think that it can provide people with relief. I'm a little more impressed with the relief from neuropathic pain than I am from fibromyalgia or musculoskeletal pain. There is evidence of gabapentin abuse on the street. Pregabalin is a controlled substance, even if gabapentin is not. There is some concern about gabapentin increasing the likelihood of a methadone overdose. And methadone, we know now, is specifically risky as a chronic pain treatment when it's closely monitored. In an MAT program, I think less so, because people have to come in and get their doses at specific visits. So I think gabapentin, it's not the worst thing to be combining with methadone, but it does have a potential downside. Nora Stern talked about, she's going to be talking about some of these innovations. I know that she's works with physical therapy. Okay. There's chatting resource about Oregon Pain Management Commission resources, about pain self-management, including patient workbooks and online programs. And I think that's the self-management resources is partly what Nora Stern. Okay, Mark Stevens asked that we provide access to these sessions for a wider audience, which is fine with me. I think, it's interesting to know that these stepped care trials showing successful intervention effects on chronic pain were coming out around the same time that the opioid crisis was peaking. So 2009, 2011, 2014, 2015. In that interval, we were basically seeing the highest rates of opioid prescribing for chronic pain. So it was almost like things were happening in two parallel universes, the universe of science and care innovation, and then what was actually happening in the primary care treatment of chronic pain, which was a whole lot of opioid prescribing back then. And that is because we were convinced by the drug companies that opioids were safe and effective, which they're not. And it is something that medical care is set up to deliver. It's very easy as a primary care provider to write a prescription. Patients loved opioids because it made them feel better right away. The downsides came later. And the availability of treatment is very good. Every tiny little town in Oregon has got a pharmacy, and they've all got opioids. But every tiny little town does not have physical therapists, much less psychotherapists, acupuncturists, mindfulness training, yoga classes. All the other non-opioid and non-pharmacologic treatments are not as widely available nor as well covered by insurance. This is kind of the unsolved part of the opioid crisis. We have made some progress at limiting opioid availability by prescriptions, although due to the transition to very lethal illicit opioids, we haven't reduced opioid overdoses. But we have not provided very effectively access to non-opioid treatments. I mean, Oregon is a bit of a pioneer in the way that it has tried to work with Medicaid dollars to steer things away from opioids and surgery. There's been a fair bit of controversy about that. Pain advocates, pain patient groups have taken Oregon to task for limiting opioid access. But the fact is that we are going to have to reallocate Medicaid dollars away from controlled substances and maybe away from medications in general if we're going to be able to fund some of these alternative treatments. So Nora has maybe one other question I'll answer before we. She wants to know if I can mention my thoughts on screening for psychosocial issues in the hospital setting. I guess that means inpatients. We have certainly started to do that here in Seattle. We have a multidisciplinary pain service at our county hospital, Harborview. I have been doing some research with our trauma patients there about what happens after discharge with opioids, but they have become much more proactive about identifying opioid use disorder while patients are in the hospital, getting people started on buprenorphine before they leave, and frankly, screening for things like PTSD and post-trauma patients. So that is better. I would say that in many settings, it's not clear whose job that is. And when that's not clear, then often it just doesn't get done. I think I'm out of time. So Ian is here and ready to take over.
Well, thank you, Dr. Sullivan, for both of your talks and answering all these questions.